So welcome to, we are on week 14, right? Yes, we are on week 14. And week 14, we are covering chapter 18, integumentary system, and chapter 19. I'm going to move the microphone closer so I don't have to yell. All right, how's that?
You sound good.
Excellent. I got tired of yelling. All right, so let's get started. Who can remind me what we are supposed to be? Were we going to go over any answers tonight?
I thought we were gonna do highlighting.
Right, we'll do that after we cover the chapter. But did I have any answers I needed to continue to go over? I think
we finished.
Did we finish them? Okay, because I want to make sure. And if you ever need copies of answers, just email me the chapter that you want copies of the answers to. Okay? So, little bit of housekeeping. I don't know how many of you over the weekend tried to get on Evolve or had issues with Evolve. I know that they had an update. And when they did the update, some of the students ended up being lost from the course. And not just one course, but all the courses that I teach. So I'm assuming that issue probably happened with terminology as well. And if it didn't, that's fine. But I just want to make you aware of it so that if you go on Evolve and your grades aren't there, or you can't access your course, or you see infinity as your grade, please take a deep breath and send me an email, and I'll get to it as soon as possible. Okay? I spent a couple hours on the phone actually, or on chat with Evolve yesterday, and I hope it fixed everybody. It's kind of hard to keep track of who was missing, so I'm just putting it out there so that if you happen to be one of those students, please just send me an email and I'll help get it fixed for you. Okay? The other thing is, please, 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 I can't stress enough to be writing down your grades on your assignment checkoff sheet. Okay? Now I know that you are, sending me emails asking me for grades. And when those grades come back to you, then I want you to go ahead and write those on your answer sheet. But what happens is in the event like what just happened over the weekend with Evolve, you have all your grades, because I have no way of recovering your grades. I do not go in and record your grades for you. I go in and I check and I look at what you did and I send you back a corrected grade, but that is the most that I do. So please, if you have any problems whatsoever, just send me an email that tells me what chapter you're on. In the subject line, it should always tell me what chapter you're working in. And this is what I was doing. Can you help me? Because this is what I was trying to do, and this is what happened. Give me as much information as possible, and probably your Evolve username would help too, because they always ask me, what is the Evolve username? And I don't honestly always know. What else? So, week 13, we're probably about halfway, right? Because we're 20 classes. So week 14, we're more than halfway. And I told you that I would start talking about the national exam. And we started last week by highlighting and bubbling. So when you did your homework this week, was that helpful for you? Did you continue with it? How did it work for you, Emily?
It worked, but I was really sporadic with it. I randomly think to do it and then I would forget to do it. I just need to take the time and sit down and do it. So it wasn't really helpful.
Okay. How about you, Lisa Fry?
The bubbling is really helpful for me.
It's been helpful, good.
Yeah.
All right. So, Darla, once you get a chance to watch the lecture, you'll understand what I'm talking about. And we'll probably do some tonight as well. Basically, it's having your CPT book. So let's go ahead and turn to your textbook. Open to page 525. We're starting with the integumentary system. And then you're going to start on page 67 in your CPT book. And you will also see in last week's lecture, oh, I forgot to post those pictures we took with my phone. Okay, I'll write myself a note to post the tabbing pictures. Okay. So in my lectures, when I'm talking to you, as I mentioned last week, you want to be highlighting and underlining what I call the key words. And in this section on page 67, you're going to see that with the integumentary system, it is one of the most often used in all of the specialties in medicine, okay? Because it's skin. So it's not just surgeons or dermatologists, it is a wide range of physicians. So what you're going to see in the subheadings of the integumentary subsection, and as you can see right here on page 61, we start right off, one of the subheadings or subsections, subheadings is skin, subcutaneous, and accessory structures. That is a subheading. So anything in red would be a subheading. So then if you turn a couple pages, you're going to find nails over on page 74. Okay, so that's the next subheading. Then we have pilonidal cyst. We have introduction. Now, who can tell me what is introduction?
Isn't it the numbing?
Introduction is an injection.
Yeah.
So yes, we get the injection with the numbing agent or the anesthesia. Now, did we go over these pages last week for
Yes.
highlighting and bubbling? Yes, we did. Okay, so I'm not going to repeat those. All right, then repair and closure. That's your next subheading. Then we have destruction. On page 87. And then we have breast on page 89. So these are the subheadings of your integumentary subsection. Okay? Now, let's start back on page 67 and talk about introduction removal. Now, again, you can follow along in your textbook or you can follow along in your CPT book, but you're going to be making your notes in your CPT book. Or I would suggest that you make them in your CPT book. All right, so right underneath introduction and removal, your introduction and removal actually ends up being a category. Introduction and removal and incision and drainage end up being a category. And the first code underneath that is introduction removal, 10030. And this reports a percutaneous image-guided fluid drainage of a catheter collection from soft tissue, such as an abscess, a seroma, a cyst, a hematoma, or a lymphocele. And they show you on page 526 what a massive carbuncle might look like on the back of someone's bottom. Okay? How someone can't know that that's happening for a while, I'm not sure. Then we have incision and drainage, which is 10040 through 10180. And so that is a category, incision and drainage. And what are we going to find underneath incision and drainage? The first thing that we have is a parenthetical note right off the top. It says, for excision, see 11400. Right underneath incision and drainage. Okay? So, for this category, you have incision and drainage of an abscess, a carbuncle, a boil, a cyst, an infection, a hematoma. What else might happen in here would be lancing, which is cutting of the skin, and aspiration. And aspiration is removal with a needle. turn the page. Then we have excision and debridement. This is your code range 11000 through 11047. This is where we have dead tissue cut away and it's washed with saline. Your 11000 and 11001 is the eczematous or infected skin. Your 11004 through 11006 is infected tissue, including the muscle and the fascia. Remember, we talked about what type of procedure and what type of site when you're highlighting. 11008 is removal of the abdominal wall, prosthetic material, or mesh for infection. And then you have 11010 through 11012, which is foreign material with open fracture or dislocation. Your 11042 through 11047 is subcutaneous muscle and bone. When we talk about an excision of a lesion, the size will be taken from the physician's notes, not the pathology report, because the storage solution actually shrinks the tissue. So you would need to pay attention to the pathology report. Usually they take the margins of the healthy tissue around the skin so that they can compare it with the unhealthy tissue. And you have an example in your book on page 71. They show you about measuring and coding the removal of a lesion. Now, you're not going to have to know how to measure it, because the measurements are going to be given to you. You just need to understand, okay, based on the measurement of the lesion, the actual charge before the excision and before sending it to pathology, what was the actual size of the lesion? Okay, so most often when physicians are doing this type of work, they will probably draw pictures of the lesion and the size of what they took around it, okay? So your lesion pathology, all of the excised tissue is pathologically examined. The destroyed lesions have no pathology samples. So if it's a destroyed lesion, we're destroying it by using laser or chemical. So it would have no pathology. So we would actually be reporting destruction when we're doing laser or chemical. And that would be your codes 17000 through 17286.
I know Brenda's like, I'm putting these up here because I've used them all day.
All right, lesion closure. Simple closure is included in removal. So simple closure is included in removal for a lesion closure. These would be for the codes around 1, 2, let me take a look here, closure. Page 75. Yeah, 75, 76. When we're talking about closure, keep in mind that a simple closure is included in the removal. You would report separately your layered or intermediate. The intermediate repair codes are 12031 through 12057. Your complex repair codes are 13100 through 13153. Keep in mind also with these codes that anesthesia, local anesthesia, is included. So you probably want to make a note somewhere in the closure section that local anesthesia is included. Simple closure is included in the removal. Okay, so let's talk about pairing or cutting on page 68. Pairing or cutting is usually done on an exam, and it is removal by scraping or peeling. That's usually going to be a removal of a corn or a callus. And your codes, there's only 3, but they indicate the number of corns or calluses or lesions. So that's what you want to remember with these codes, is the number of lesions. Biopsy, 11100 through 11101. Only 2 codes here. This is for skin and subcutaneous tissue or mucous membrane biopsy. Not all of the lesion is removed. If all of the lesion is removed, it would be excision. Okay? And you want to keep in mind for this that you do not use a modifier 51. Again, your codes indicate the number and each additional. As you notice, there's a plus sign. Your plus sign is the add-on code. Skin tag removal at the bottom of the right-hand column on page 69, 11200, 11201. Over on the next page, it's only 2 codes. One is the standalone, one is the add-on. It is usually, they are benign lesions. They are usually removed with scissors, blade, chemicals, electrosurgery. Again, do not use modifier 51 with these. And your codes here also indicate the number. So up to 15 and each additional 10 lesions or part thereof. Okay? The shaving of lesions.
Here I am, I'm back again.
Well, that's good.
I hope. Now somebody, I had a room right here that I could buy a cup of coffee here.
Okay, the shaving of epidermal or dermal lesions. These are codes 11300 through 11313. Again, we're looking at, is it simple? Is it single? What is the size of the lesions? A lesion is removed, but it's superficial and it does not extend into the fat. Okay? It is removed by transverse incision or horizontal slicing. All right, hold on just one moment, please.
Yeah, I'll get you started through the night or whatever. Keep you
All right, can everyone hear me?
I can hear you.
Okay, good. All right, so I just basically got rid of the extra noise. All right, so shaving of lesions. The lesion is superficial. It does not extend into the fat. It is removed by transverse incision or horizontal slicing. The documentation should state shave removal. Again, these are all based on size and location. So when you're highlighting and underlining, you want to highlight and underline the location and then highlight or underline the sizes. And these are actually 3 I think we bubbled last week, okay? They do not require suture closure, okay? They might just use those steri strips or something like that to keep it together for a little bit. You would report the most extensive first with no modifier, then the least extensive lesion from a different body area with modifier 51. Okay, so if we had this big one on the scalp, and then maybe we had one on the forearm. The one on the scalp was more extensive. That one would be with no modifier. The one on the forearm, because it's a different body area, you would append a modifier 51 with that. Now, if they take a biopsy, do not assign code 11300 through 11313. Instead, you would select a shave biopsy, which is your 11100. And it should tell you right there. Again, reading the notes, okay? All the notes throughout will make a big difference. Benign and malignant lesions on page 71 in your CPT book, 70 and 71. These are codes 11400 through 11646. The codes are divided whether or not they are benign or malignant. The physician will assess the lesion as benign or malignant, and they should state that in the notes, okay? The codes here include local anesthesia and simple closure. So you would want to make a note somewhere in your white space here that these include local anesthesia and simple closure. You can write it right across the top of the page up there. You would report each excised lesion separately. A lesion is removed and the excision extends down to the fat. That would be considered a full thickness removal. Okay? Nails. On page 74 in your CPT book, Your nail codes are 11719 through 11765. These are both toes and fingers. The types of services that you would see here would be your trimming, your debridement, your removal, your biopsy, your repair. Okay, and that is exactly how I would highlight those codes, is based on that terminology: trimming, debridement, removal, biopsy, and repair. Your introduction codes, 11900 through 11983. These are types of services. What do I mean by that? These are the words I would highlight: lesion injections, tattooing, tissue expansion, contraceptive insertion and removal, hormone implantation services, and insertion and removal of non-biodegradable drug delivery implant. Those are the keywords I would code there, highlight. Going back to the repair closures,
Doreen, would you mind going over them one more time?
the types of services:
No, the ones to highlight.
lesion injections, tattooing, tissue expansion, contraceptive insertion and removal. So basically you want to know removal or reconstruction or replacement. Implantation services, hormone implantation services, and then any type of insertion and removal of a non-biodegradable drug delivery implant.
Thank you very much.
You're welcome. So the repair closure wounds codes, page 75 again. These are your codes 12001 through 13160. You actually have some pictures in your book on page 538 and 539 that give you the different types of wounds that vary. The types of wound repair also varies. Okay? So you have simple, you have intermediate, and you have complex repair. Now, your repair factors in your wound repair. Okay? What do I mean by that? Simple is the complexity. Scalp is the site. And length would be, 2.5 centimeters or 0.5 centimeters. All right. If you look at all of these repairs on page 76 and 77, you'll see they each have their own subheading. All right. Repair simple, repair intermediate, repair complex. And you see by the diagrams in your book, they show you the different types. So your length is your complexity. Then you have is whether or not it's simple, intermediate, or complex. And then you have it by the site. So in all of these subheadings, you want to know the anatomy. So where is it? Where is it? What's the complexity? And then what's the size? So those are the types of things I would look to highlight or underline. Now your simple repair is superficial, and it gives you a good picture, in your textbook on page 539 of the different layers. So the simple is superficial, It is the epidermis, the dermis, and the subcutaneous tissue. It's basically your one-layer closure, okay? You can suture it, you can steri-strip it, you can staple it. It's measured prior to the closure, end to end. And they can use Dermabond, all right? So if they were using a HCPCS code for Medicare, you would report G0168. So Dermabond closure, Medicare, G0168. You can just stick that by simple repair somewhere. Then we have the intermediate. Your intermediate wound repair is layered closure of one or more of the deeper layers of the subcutaneous tissue and the superficial fascia with skin closure. A single layer closure can be coded as intermediate if you have extensive debridement required. Your complex wound repair is greater than layered, so such as a scar revision, complicated debridement, extensive undermining, stents, extensive retention sutures. That would be your complex. What else would be included in your wound repair codes? Simple ligation of the vessels in an open wound, simple exploration of the nerves, the blood vessels in your exposed tendons, normal debridement. Some additional codes for debridement are reported when you have gross contamination. And gross contamination might happen when, let's say you have a motorcycle accident and you get scraped along the tar or something. That would be gross contamination. Got a lot of debridement you have to do too. Also, appreciable devitalized contaminated tissue must be removed to expose the healthy tissue. All right? Kind of like when they tell you don't pick your scabs. Well, in this instance, you really want to be picking away at everything so that you don't get infections. Okay? So a really good cleaning. When you're grouping wound repairs, you're going to add together the lengths by the complexity. So are they all simple, intermediate, or complex? Then you're going to do it by location. Face, ears, eyelids, nose, lips. Okay? Keep in mind 1 inch equals 2.54 centimeters. So at the bottom of your page somewhere, you might want to write yourself a little note. 1 inch equals 2.54 centimeters. What you do not want to group when you're doing wound repairs are the different complexities. Like I mentioned earlier, we had a really extensive one on the scalp, but a really simple one on the forearm. You do not want to combine those two, okay? If there are different locations stated in the code description, simple repairs of the scalp and nose, then that's how they are. Different locations. Your tissues, tissue transfers, grafts and flaps. Page 77, 78. These are codes 14000 through 14350. This is adjacent tissue transfer or rearrangement. So if you see an exercise that says Z-plasty or W-plasty or rotation flaps, first thing that should come to mind is tissue transfer. So right on page 77 in that paragraph, highlight Z-plasty, W-plasty, and VY-plasty, rotation flap, random island flap, and advancement flap, so that those stick right out for you. Your adjacent tissue transfers, they include excision of the lesion. They include excision of the lesion. Some information that you need to code grafts are the type of graft. Is it adjacent? Is it free? Or is it a flap? Where is the donor site? In other words, where is it from? What is your recipient site? Where is it going to? So are you taking it from your thigh and putting it on your nose? Okay, where is it coming from? Where is it going to? Is there any repair to the donor site? So if they take a layer of skin off, do they need to do any repair to it? What's the size of the graft? And what is the material used? Your split thickness and full thickness grafts. Your split thickness graft is your epidermis and some dermis. On page 542, they show a couple different types of tissue transfers. And on page 543, they show you figure 18-22, a split thickness skin graft and a full thickness. Your full thickness is the epidermis and all the dermis. And I think in the front of the book in your anatomy pages, you might have an illustration. So when they do graft types, they might use a skin substitute, which is our artificial skin, which is a bilaminate skin substitute. So a skin substitute might be the bilaminate skin substitute. An autograft or an allograft donor is tissue that is cultured, epidermal autografts that are grown using donor cells. And then xenograft is a non-human donor. So skin replacement surgery on page 78 and 79 in your CPT book, that's a page you should read. Pay attention to the definitions. Pull out the skin substitute, the allograft versus the autograft, and the xenograft. I'll give you a minute to find those. All right, tissue transfers, grafts, and flaps. We're talking about skin replacement surgery. Your skin replacement surgery are codes 15002 through 15278 on page 80. This is your surgical prep, your skin replacement surgery. And then our flaps are on page 82, 15570 through 15777. The flaps are where some of the skin is left attached to a blood supply. And they show you that on page 545 in your textbook. Let's go back to page 80 just for a moment in your CPT book and talk about the skin replacement surgery codes. These codes are going to report the site preparation and the repair using the skin or the skin substitutes. The defect site, which is the recipient site, repair is reported with 15002 through 15005 based on the size. Your free skin grafts, such as 15100 and 15101, are your split thickness or your full thickness. This is where they are completely freed from the donor site and placed on the recipient site. Your flaps, as I was talking about on page 82, this is where some skin is left attached to the blood supply. It helps keep that flap viable so that the donor site might actually be far from the recipient site, so they want to keep that alive. And the flaps are actually going to be done in stages. So you'll see by your codes on page 82 and 83 that they talk about where they're forming it. So the formation is based on what part of the anatomy, the trunk, the scalp, the nose. So your codes 15570 through 15577. Then you have the transfer, the 15650 code. They take the previously placed flap and they release it from the donor site. This is also known as walking or walking up of a flap. So next to code 15650, you might want to put yourself a little note that says, or highlight right there, walking. Your flaps can be muscle, myocutaneous, or fasciocutaneous flaps. These are codes 15732 and through 15738. The repairs are made with muscle, muscle and skin, and fascia and skin. Your flaps are usually rotated from the donor site to the recipient site, and this would include any closure to the donor site that's needed. Your codes are divided on location, trunk, and extremity, and then your add-on code would report the soft tissue reinforcement with biological implants. And they show you a tube flap on page 545 in your textbook. On page 85 in your CPT book, we're going to talk about pressure ulcers, code 15920 through 15999. You're going to see in these codes excision and various closures. So primary, skin flap, muscle, and you're going to see a lot of codes with ostectomy, which is bone removal. So if you're not aware of that, right next to one of these codes, bone removal, ostectomy, bone removal. Also keep in mind with these codes, what is the location? So coccygeal is the end of the spine. Sacral is between the hips. Ischial is the lower hip. And the trochanter is the femur. Your site prep only codes will be the 15936, 15946, and 15956. Your defect repair would be reported separately. Your burns, on page 85 and 86, your burns, you're going to code for small, medium, and large. Most of your calculations are percentage of the body burn, which is your rule of nines. You will see that on page 549 in your textbook. But you also have an example or a chart in your CPT book on page 86. So they tell you the different areas of the body, how old the person is, and how much that percentage would be. So if you had to figure out the percentage of a person burned, this is what you would use. But most often that would be in the report already from the physician's notes. The rule of nines for adults, anything that's less than 5% is small. Medium would be 5 to 10%, and then large would be greater than 10%. And you would use the Lund-Browder for the children. That helps you. It gives you the proportions of children differing from adults. Your burn codes, you really only have 6 of them. 16000 through 16036. Often they require multiple debridement and redressing. They're going to be based on, is it the initial treatment of a first degree burn, and what is the size? And then report the percent of the burn and the depth. So for those 6 or so codes from page 85 to 87, you'll see that it's based on the initial treatment and the size, and then the percentage of burn and the depth. So not many codes, but you just need to be aware. Your destruction codes. This is usually ablation of tissue. So when we hear ablation, it is destruction. And it's right there in the first line. Destruction means the ablation of benign, premalignant, or malignant tissues by any method. Okay? That could be laser, electrosurgery, cryosurgery, chemosurgery. You have parenthetical notes here. Make sure you've read them. Destruction is also for benign and premalignant or malignant tissue, and it's based on the location and the size. Over on page 88, the Mohs microscope, page 551 in your textbook. The Mohs microscope, 17311 through 17315. This is where the surgeon is acting as the pathologist and the surgeon. And you notice in your CPT book, you have a standalone code and an add-on code, a standalone, an add-on, and an add-on. You only have 5 codes on page 88 and 89. The physician removes one layer of lesion at a time until no more malignant cells remain. It's based on location, stages, and number of specimens stated in the report. Over on page 89, your breast procedures, 19000 through 19499. They are divided based on procedure. And what are those procedures? Those are in blue underneath the subheadings, okay? So it'd be incision, excision, over in the right-hand column. Turn the page, 90, introduction. Next page, 91, mastectomy procedures. And then over on page 92, repair and or reconstruction. So again, you want to know, what are they doing in each one of these? Reduction, removal, reconstruction, correction. Highlight the words that are going to stick out for you of what is being done in that code. You don't need to highlight the whole line, because then you won't see that one word that's going to stick out that means what they're doing. Okay? And also pay attention to size. Okay? Is it radical? Is it modified radical? Simple, partial, percutaneous, open. All right, your mastectomies, they are based on the extent of the procedure. So I just said it, simple, radical, or modified radical. I got ahead of myself. Your bilateral procedures, you would use a modifier 50. So you would code the first one, and then the second one, modifier 50. Then implant insertion would be billed separately. That would be your 19340, 19342 code. If a lesion is removed from the skin of breast, you would use one of the 11400 codes. If the lesion is removed from the actual breast tissue, use 19120. When they talk about introduction, back on page 90, sorry, and they show you on page 553, introduction in your textbook. What introduction does is it's a marker or localization device that's inserted into the lesion to mark the lesion. That would be reported separately. And it would be reported based on guidance used, and you would use codes 19281 through 19288. So usually an introduction for a breast code is basically to see what size the lesion is, where is it. And that is it for integumentary. Any questions in this chapter right now? How did you do your homework? How was your homework?
A lot. The theory and practical I could find on one of the chapters in the book. I can't remember if it was 18 or 19. I didn't finish.
Okay. So let's do the theory and practical. All right, so what are the three things? Number 1, 2, and 3. In any order, Emily?
Ligation, exploration, and debridement.
Yes, ligation, exploration, and debridement. 4, 5, and 6 in any order: length, complexity, and site of repair. And 7, 8, and 9, any order: simple, intermediate, and complex. Number 10 means modifier 51 means multiple procedures. 11, guidelines. Page 556 and 557 in your textbook.
Thank you. Cheers.
12 is debridement. 13 is punch. 14 is tissue expander. 15 is autograft. 16 is benign or malignant. 17 is site and size. 18, dermabrasion. 19, pathologist. And 20, excisional. For the practical. So number 21, Margaret Wilson, a 26-year-old mother of 3. She's a new patient. Has routine screening mammography of both breasts, so you do not need to code the mammography. A shadow is visualized in the right breast. The physician performs a biopsy, needle core. The biopsy indicates malignancy. The patient agrees to and has a mastectomy, simple, complete, 1 week later. There is no global period on this procedure, and the pathology report indicated a primary malignant neoplasm. So they told us to code the breast biopsy 19100, and then you would do a simple mastectomy complete 19303 with an RT modifier. The diagnosis code, they told us it was a primary malignancy of the breast, 174.9. Number 22. These are skin tag removal, so lesions, skin tag removal, 11200. And then your diagnosis is a skin tag, 701.9. Number 23, 15120 for the first 100 centimeters of the split graft, 15121 for the additional 80 centimeters of the split graft. Then you have 15004 with a modifier 51 for the first 100 centimeters of the site prep, and 15005 for the additional 80 centimeters of the site prep. Okay? Your diagnosis code for that, it's a Nevis strawberry. That was pretty simple to get to. 757.32. 24, Emily, how would you do 24?
Do you want my answer for it?
No, I want to know how you got it.
I didn't write it down.
Okay, but look at it. What do you think you did?
I would have gone to procedure.
Which is? What type of procedure?
It's a complex, right?
Well, what did they do?
The reconstruct.
Reconstruction.
Okay.
Yes, reconstruction. So this is what I want you to try and think of when you're doing your exercises. All right? And I think this is what's messing people up. Think about what it is they're doing first. So, nipple reconstruction. We know the anatomy. It's the breast. But what are they doing to the breast? They are reconstructing. What are they reconstructing? The nipple. So we're going to reconstruction, breast, nipple. Okay? So you should have 19350. Okay? All right, 25. Destruction of 0.4 centimeters malignant lesion of the neck. So what are they doing here, Emily? Destruction. Destruction of what?
A malignant lesion.
So destruction of a lesion. It's also part of what system? The skin. Okay, a lesion is on the skin. And it happens to be malignant. So we're doing destruction of a lesion on the skin, malignant. So you should have 17270. All right, 26. Simple repair of a superficial wound of the genitalia, 2.4 centimeters. So it's less than an inch, right? All right. What is it? Don't tell me what they're doing yet. Tell me what it is. It's a wound.
It's a repair.
What are we doing to that wound? Repairing that wound. And what type of repair?
Simple.
Yes. Okay, is this helping?
Yes. See, when I'm at home doing these, I get them, but I sit here for so long trying to do that and think it out in my head.
Yeah. So you should have 12001. All right, 27. Adjacent tissue transfer of a chin defect, 9 centimeters. So we know that's over how many inches?
Oh, it's 2 inches. 2, 4, 6. Is it 6?
Roughly. But we don't need to worry about the centimeters right now because we're not looking up the, we don't need it right now. But, so it's an adjacent tissue transfer. But where do we have to start? With what system? We're doing a transfer of what? Tissue.
Skin.
What is tissue part of? Skin. So we're going to start with skin and do adjacent tissue transfer. And that would be 14040. Okay? All right, let's go into the workbook. Did everyone do the workbook or only up to a certain point?
I did this whole chapter. It's 19. No,
I did this.
Finish the report.
Okay. And did everyone finish 19 in the workbook?
No, I did not.
Okay, so we probably won't go over all of it. We might pick up some of the ones that you didn't do and go over those. All right. So in the workbook, number 1, we're matching. 1 is B, 2 is D, 3 is I, 4 is G, 5 is A, 6 is J, 7 is F, 8 you could have H or E, 9 is C, 10 is E or H, and 11 is A. 12 is D, 13 is I, 14 is G, 15 is C, 16 is H, 17 E, 18 B, 19 F, 20 B, 21 D, and 22 A. All right, number 23. As I said, you have all your odd ones in the back of the book, so I'm going to only give you the even ones so that we can get through the next chapter tonight. 24. You should have 12016, and I want you to stop me where you guys stopped. Okay? 12016 is your CPT code for the repair simple wound, and then 99070 is for the supply. All right? Your diagnosis code would be 873.41. You're not going to code an E&M here because this is an established patient. And the treatment is actually constituting the main service for this particular exercise. Does that make sense to everyone? 26, 99024 with diagnosis V67.00. 28, 11043 with diagnosis 250.80 and 70715. 30, 11772 and 685.0. 32, 11720, 110.1. 34 is 11643, 11602, modifier 51 times 2. And your diagnosis codes 17300, 17350. I'm not going to put the decimals in there. You should have those in there. 36, 17284, and 17310. 38, 17271 with 173.40. 40, 'Laser destruction of multiple malignant lesions as follows. 3/4 centimeters on the right hand, 2.1 centimeters on the left hand, 5.2 centimeters on the right hand, 4.3 centimeters on the left hand, 0.3 centimeters on the right eyelid, and 0.5 centimeters on the left eyelid. So, 17276 times 2 for the destruction of the lesion. This is for the two hands, okay? Then you have 17274 modifier 51 for the 3.4 lesion on the hand. Then you have 17273 modifier 51 for the 2.1 lesion on the hand. and then 17280 modifier 51 times 2 for the lesions and the eyelids. Do I need to repeat any of those? Your diagnosis codes would be 17360 for the hands, 17310 for the eyelid. Your skin here is not a paired organ, so therefore you would not have to use LT and RT. All right? And you're going to have 2 sets of codes for each diagnosis because the neoplasm chart actually conflicts with the tabular on these codes. So that's why we have 2. 42, 15822, and 15822 modifier 50, or, count it one of 2 ways, 15822E1 and 15822E3, because that indicates the digit, right? Your ICD-9 code, 374.30. 44, 17313, and diagnosis 173.60. Now your reports, number 46. I think we did one in class, a couple of these in class, right?
Did we? I didn't write them down, but I did.
Okay, number 46, you should have 11423 with diagnosis of 709.2 for a scar. '48, 11042 and 11045 with a diagnosis of 686.9. '50, 15839 for the excision of the excess skin with diagnosis 701.9. And that should be it. How did everyone do with those?
Mediocre.
Okay. You know what means more than anything? Is that you tried them. Honestly, that you tried them.
I googled the one that you were.
That I said to Google, right?
I don't know. No. It was that one. It was number 40 that I googled, and it was one of those Wik answers, and somebody asked the same question about it, and it gave a really nice explanation though as to how they got it.
Good.
So it was helpful.
Good. Yeah, I think I told you to Google the pressure ulcer.
Yeah.
What was it? The pineidal something or other. Yeah. All right, chapter 19 is actually pretty simple. It's the musculoskeletal system. So in your CPT book, make sure you're open to page 93. You will see here that it gives you some illustrations of the skull, the skeleton, and over on page 94, the vertebrae, the vertebra, the lateral view, the superior view, and then the front and back, and the muscle groups. This would probably be a good place to know where to turn if you have questions about this type of stuff. You'll also turn to page 96 and 97. They have some good illustrations on the hands and the feet and the bones and the muscles. So on page 98 in the CPT guidelines, the musculoskeletal system, the subsections are divided by anatomic site. So the forearm, the wrist, and then by the cervix. So anatomic site and then cervix. You'll see that these codes are used extensively by orthopedic surgeons. Many of the codes are commonly used by a variety of physicians. You'll see a lot of extensive notes throughout here, as you see already, on page 98 and 99. Some of the most common things that you will see in here will be fracture and dislocation treatments. We start off the section with a general subheading on page 99. You will have arthroscopic procedures and casts and strapping. When we talk about fractures and when we are coding fractures, here are some of the things you want to think about, and you don't need to write these all down. These are just something you want to think about when you're coding a fracture. What is the site of the fracture or the dislocation? So if you look in this section, as we said, it's by anatomic site and by cervix, right? So what is the site of fracture or dislocation? What is the type of treatment? Is it open or closed? Okay, right on page 98, about halfway down the page in that first column, the type of fracture, open, compound, closed. Left-hand column about midway. Type of fracture, open, compound, closed. Then we want to know, is the manipulation performed and documented? Was traction used? If so, what type? Did they use a percutaneous fixture? Was there an internal fixation applied? Make sure that that is not included in the code description, because if it is, you're not gonna, then you might not be choosing the correct code. Was there an external fixation system that was applied? Does the documentation support skin closure? And then what type of anesthesia was used? Your fracture treatment, open. That's the first type. This is where it is surgically open to view it or remotely open it to place a nail across the fracture. This might also be called open reduction or internal fixation, also known as ORIF. And I'm sorry, it is open reduction with internal fixation, ORIF. Sorry. Page 561 in your textbook. Your closed treatment. The fracture site is not exposed by surgical incision. Percutaneous is neither open or closed. Your fixation devices such as pins are placed across the fracture site under imaging. Your treatment terms are not to be confused with the type of fracture. So if it's an open fracture, that means what? That the bone penetrates the skin. If it is a closed fracture, the bone does not penetrate the skin. So what do we do for fracture treatment? The type of treatment is going to depend on the type and severity of the fracture. So if you look at page 560 in your textbook, they give you figure 19.1, and it shows you all of the different types of fractures. Complicated is a code descriptor that may indicate excessive hemorrhage, infection, prolonged physician work, or difficulty in reaching the site or the depth of the site. Over on page 563, traction is the application of force to align the bone. So 563 in your textbook. Traction is the application of force to align the bone. Skeletal traction is the use of force, distracting or traction force applied to internal device, such as a wire, a pin, a screw, or a clamp. It's inserted into the bone. Your skin traction is application of force by means of adhesion to the skin. They show you all of these right there on page 563. And what is manipulation? Manipulation is the use of force to return a fractured bone to normal alignment. Your fracture repair codes are often divided based on whether or not manipulation was or was not used. It is also known as reduction. So, manipulation means that a fracture has been reduced. Now, some of the fracture terms that you might hear are described in the book. Your fractures are described by the physician in terms of direction of the fracture, whether it's horizontal, vertical, oblique, or spiral. And then the direction and the degree of the angulation, so the most distal fragment. And when the fracture results in more than 2 fragments, it is considered to be comminuted. Over on page 564 in your textbook, dislocation. This means that the bone is displaced from the normal joint position. The treatment is to return the bone to normal joint location. And how do they do that? They do it by manipulation. So we start off our musculoskeletal system on page 99 with the general subheading. And we start off with code 20005, and we go all the way through to 20999. And it actually begins with the procedure of incision. And you see it's right all by itself. The depth is the difference between integumentary and musculoskeletal incision codes. Your musculoskeletal is used when the underlying bone or muscle is involved. Some of the other subheadings you're going to see will be wound exploration. The wound exploration has to do with traumatic penetrating wounds. And you're going to see that these are divided on the wound location, which is also going to be the body site. So in these, you want to know what is the anatomy, what's the body site, the chest, the abdomen, the extremity. You will also see that it will include enlargement, debridement, foreign body removal, ligation, and repair of tissue and muscle. Underneath the wound exploration, these procedures describe the surgical exploration to an already open wound. So these codes are separate procedure codes. They can be coded and reported in the following circumstances. If only the procedure is performed, you can do that. Or if it's totally unrelated to another procedure performed at the same session. So what do you think I mean by that, Emily?
I don't know.
What do you think, Darla?
I do not know.
What do you think, Lisa?
Could you ask me it one more time?
So these particular codes,
Mm-hmm.
all right, they can be coded and reported in the following circumstances. If only the procedure is performed, or if totally unrelated to another procedure performed at the same session.
I don't know.
Okay. So if we look at our note here for wound exploration, it says that it relates to wounds resulting from penetrating trauma. These codes describe surgical exploration and enlargement of the wound, extension of dissection to determine penetration, debridement, removal of foreign body, ligation or coagulation of minor subcutaneous and or muscular blood vessel, of the subcutaneous tissue, muscle fascia, and or muscle, not requiring thoracotomy or laparotomy. If a repair is done to major structure or major blood vessel requiring thoracotomy or laparotomy, then those specific codes would supersede the use of codes 20100 through 20103. To report simple, intermediate, or complex repair of the wound that do not require enlargement of the wound, extension of dissection, etc., as stated above, use repair codes in the integumentary section. So if we did an exploration of the penetrating wound for the chest, we could code that by itself. Okay? Because we're doing an exploration of a penetrating wound to just the chest. Now, if it is totally unrelated to another procedure that is being performed at the same session, then we can also code the 20101. Okay, does that make sense?
Well, no, can you give an example of that?
So, say the patient comes in from a motor vehicle accident, and we know that they had something totally mess up their leg. But as they're undoing the clothes from the patient, they see that there's another wound, let's say to the chest. So they go in and they do a wound exploration on the chest. It's totally unrelated to this procedure being performed on the leg.
But wouldn't it be related if it was because he came in from an accident?
Right.
Wouldn't they do a total body, you know?
But you can do separate procedures. You can do the extremity and you can do the chest.
Okay, I see what you're saying. The different body parts, you mean?
Right.
Okay.
Right.
Okay.
But then if he was in an accident and there was nothing else showing, say there was no visible trauma, but then as they're undressing him, they see something going on with the chest, then that would be separate all by itself.
Because he came in with a different complaint?
Well, because they didn't see any, no. He's still in a motor vehicle accident.
Yeah.
Hypothetically.
Mm-hmm.
There's no visible trauma.
Okay.
Okay, there's no visible lacerations or anything right off. They get him in, they start undressing or cutting or whatever they have to do when they're checking, and they see that there's a wound or something, then they go in and they do a wound exploration. You just have to kind of think of the scenarios. What could it be? What, that type of thing.
Yeah.
Yes, no, maybe?
Sorta.
Okay. Basically what they're saying here is with these 4 codes, they can be coded separately. You've got the neck, the chest, the abdomen, the extremity. But what you want to be aware of is which one is going to be more severe also. The most severe one always gets reported first. Okay?
So it does have to do with the site. So it's a totally different part of his body. So
Right.
that's why it would be coded separate.
Right.
Am I understand? Okay.
Yes. Yes, I may not always be very clear. So you have to ask questions. All right, biopsy. Biopsy is located in the excision subheading 20200 through 20251, 20200 through 20251 over on page 100 in your CPT book. These are biopsies of bone and muscle. They are divided by type of biopsy, bone and muscle, depth, and some by method. So those are the things you would want to look at when you're highlighting and underlining, and pay attention to your parenthetical notes. Okay? So you see biopsy of the muscle, biopsy of the bone, open, superficial, open, thoracic, lumbar, cervical, injection. Okay? Then can it be percutaneous needle or excisional? If it's a percutaneous needle or excisional, that would be separate, coded separately. If you have a lesion that is excised and biopsied, only the excision can be billed. Why do you think, Emily?
So, can you say it one more time?
If the lesion is excised and biopsied,
Yeah.
only the excision can be billed. Why? It's the more time intensive.
Okay.
So excising it is more intensive than just kind of scraping it off, because the lesion is also being biopsied. So they're going to make a bigger hole, okay, to excise it. If the biopsy is taken on one day and based on the results an excision was performed, then a modifier 58 might be appropriate on the excision code because they've decided that they take the biopsy on one day, but they're going to have to go back and do the excision. Okay? On page 100, your introduction or removal subheading. This is within the general subheading, and you're going to find in the introduction or removal codes, you will have injections. So these are the things I would highlight. Injections, aspirations, insertions, applications, removals, adjustments, the therapeutic sinus tract injection procedures, believe it or not, are not nasal sinus. These are an abscess or a cyst with a passage to the skin, with a sinus tract passage to the skin. This is where antibiotic is injected with the use of radiographic guidance. Your removal would be foreign bodies that are lodged in the muscle or the tendon sheath. Your integumentary removal codes would be for the removal from the skin. Keep in mind, if it's skin related, you're going to use your integumentary codes. Injection would be into the tendon sheath, the ligament or the ganglion cyst or the trigger point. Arthrocentesis. Arthrocentesis is injection and or aspiration of a joint. So over on page 101, I give you a good example right there. You only report that with one code. This is both the aspiration and injection that is reported in that one code. Local anesthesia is integral to these codes, and it should not be reported separately. You would, however, report the drug code separately with a J code from your HCPCS book. And your HCPCS modifiers would be used to report specific digits, as we've mentioned before, the FA to the T9 or the TA to the F9. You have it in the front of your CPT book, you know, in the inside cover. You also have it in your HCPCS modifier book, and your HCPCS in the modifier section. External fixation. Over on page 102. External fixation. These are codes 20690 through 20692. This is application of a device that holds the bone in place. These codes include the removal of the fixator. If it is necessary to adjust or revise an external fixator, you want to look at code 20693. Code 20694 actually describes removal under anesthesia and would include imaging. So what you want to look at for highlighting in these codes would be application of halo, removal, adjustment, Also, uniplane. What is a uniplane? It is pins or wires in one plane, usually a flat, smooth surface. What is a multiplane? It requires complex adjustments and correction in alignment. Bedside adjustments are not separately billed. You would code the fracture treatment and the external fixation. Unless, of course, in the code descriptor, it says both. Because remember, in our code descriptors, sometimes it says both. On page 103 in your CPT book, grafts or implants, these are codes 20900 through 20938. These are going to be used to report your harvesting through the separate incision. And you would see the separate incision of the bone, the cartilage, the fascia lata, and the tissue. So those are some of the keywords I would look for in those codes. Bone, cartilage, fascia lata, and tissue. Your grafts and implants also involve morselized or structural bone that is taken from a donor or from the patient. If it's taken from a donor, it is an allograft. If it's taken from a patient, it is an autograft. Morselized means small pieces of bone, and structural is a segment of bone machined into the space. You want to report only one bone graft per operative session. Your fascia lata grafts happen from the mid-upper thigh where the fascia is thickest. Some of your grafts include obtaining the grafting material. Then, if that's the case, they're not coded separately. Your composite grafts would involve combinations of autogenous material and allograft or alloplast. On page 104, right-hand column, some of the other procedures in this section would be monitoring muscle fluid pressure. This is where the pressure increases due to increased accumulation of fluids causing the blood supply to be compromised. Bone grafts that are identified by site, they are taken from the donor site. So you'll see that in these codes underneath other procedures. Free osteocutaneous flaps are bone grafts. They're usually taken along with skin and tissue overlying bone. Electrical or ultrasound stimulation is used to speed the bone healing. Placement of stimulators externally or internally. When they use electrical or ultrasound stimulation, that's actually used often in treatment of fractures. What that does is it helps to speed up the healing of the bone. The spine, the vertebral column, on page 572 in your textbook, codes 22010 through 22899. Over on page 111 in your CPT book, it starts on the left-hand column. These are divided by the repair location. And as you saw earlier in the book, you had anatomical illustrations. You have a lot of notes in this section. Cervical is C1 through C7. C1 is your atlas and C2 is the axis. Your vertebral column is made up of cervical, thoracic, and lumbar spine. Thoracic is T1 through T12. Lumbar is L1 through L5. Then you have sacral, which is the SI, and coccyx, which is the tailbone. Turn the page to 112. Underneath our incision category, you see two codes. You have open incision and drainage of the deep abscess of the spine. You'll see that it is divided by location: cervical, thoracic, or cervical thoracic, lumbar, lumbar, sacral, and lumbosacral. Your arthrodesis are your codes 22532, 22532 over on page 115, and 22819. This arthrodesis is the fixation of a joint. You will fixate it with pins, wires, rods, and to immobilize the joint. Often you'll see this will be performed with other things such as a fracture repair. You can use a 51 on an arthrodesis code, but not on an add-on code, unless the service is reported with an add-on code. So let me clarify that. You can add a 51 modifier on an arthrodesis code if it's an add-on code. These are going to be coded by the approach, the site, and the number of interspaces and segments. Your spinal instrumentation, 22840 on page 118 in your CPT book. The types of spinal instrumentation, segmental and non-segmental. Segmental are your devices at each end of the repair area plus at least one other attachment. Your non-segmental are devices at each end only. You have extensive notes throughout here as well. And you would report in addition to the definitive procedure without the 51 modifier. Again, pay attention to your code descriptors because they may already include the fact that this is an additional code. Some of your subsequent subheadings after the first would be divided by anatomic location. So you see on page 121, we have abdomen. And then we have shoulder. And then what you're going to find underneath each one of those is that it's divided by procedure. So incision, excision, manipulation, head prosthesis, introduction or removal. I'm on page 122. 123, repair, revision, and or reconstruction. These are your procedures. You're going to see the majority of these procedures throughout the rest of the CPT book. So get used to seeing them. Fracture and or dislocation, and then other procedures. Your cast and strapping, 29000 through 29799, all the way at the end there. What page? Page 156 in the CPT book. Cast and strapping, 29000 through 29799. This is a replacement procedure or initial placement. Usually it stabilizes without additional restorative treatment.
Can you
The
tell me
initial
what page
fracture,
again? I'm
sorry?
sorry. Can you tell me what page again in the CPT?
156.
Thank you.
You're welcome. So this is the initial fracture treatment includes placement and removal of the first cast. Any subsequent cast applications are coded separately. The initial cast is not coded when it's part of a surgical procedure. And removal is actually bundled into the surgical procedure, and your supplies are reported separately. And as you can see, the application of cast and strapping go by body site. So body and upper extremity, lower extremity. Okay? Then on page 158, we have endoscopy and arthroscopy. 29800 through 29999. Your surgical arthroscopy is always going to include diagnostic arthroscopy. It says right there, underneath the heading, surgical endoscopy and arthroscopy always includes a diagnostic endoscopy and arthroscopy. The codes here will be divided by joint. So you want to highlight by joint and then subdivided by procedure. So highlight the joint and highlight the procedure. You're going to see a lot of parenthetical information in these codes because it will indicate which code to use if the procedure is an open procedure. Okay? Most of your arthroscopies are going to include local infiltration of the medication, suture removal, surgical approach, wound culture, intraoperative photos, isolation of the nervovascular structure, stimulation, placement of drains, wound closure. Okay, keep that in mind, but read your notes. Okay. Any questions? All right, let's do the review and practical in the textbook. Okay, number 1 is anatomic. Number 2 is any physician. What is 3, Emily?
I have closed, open, and skeletal fixation. Do you want to know what each one is too?
No, you know where to find them in the book. You also, yeah, that's good. 4 is extent or type. 5 is traction. 6 is manipulation. 7 is reduction. 8 is dislocation or dislocated. 9 is debridement. 10 is trocar. and 11 is yes. "12. This should be incision and drainage of an abscess. 20005. "13. Tumor of the back flank radical resection. 21935. Number 14. This is a fracture code 22305. You would not indicate 3 units here, just 22305. Number 15 would be 23700 RT for the right shoulder. Also be aware that both the manipulation and the application of the fixation are going to be described in the code. Number 16, you could have 24305 times 4 or 24305 and 24305 modifier 53 times 3. I'm sorry, 24305 modifier 51 times 3. You will note in the code book it says each, okay? What it comes down to in the real world is what does your payer want, all right? Number 17, 23931. 18, 25628. 19, 26530 times 2, or 26530 and 2653059. 20, 26455 times 2, or 26455 and 26455 modifier 51. Because again, the code is specifying each. 21, 25915. 22, you want 25575. And 23, 25392. With diagnosis 732.8. Do I need to repeat any of those?
Number 23, the first one.
Okay. 23, 23 is 25392. 24, 24357. And 726.32. And then 25, 20802 with an RT modifier. And then 887.2. All right, in the workbook, Lisa, how far did you get in the workbook?
On 19, I had just started. I had everything else done but that.
Okay. How about you, Emily?
I made it to 21, and I did that 21 work before class. That was 21.
Okay. All right, and Darla, none, right?
Right.
Okay. So why don't we go ahead and pick out some and do them together in class?
Yeah.
Does that sound all right?
Yeah.
Let's do the even numbered ones so you can check your odd numbered ones in the back of the book. All right, so number 22. And what we'll do, just remind me please next week to go over the answers, okay? 22. John is returning to the physician's office 2 weeks post-surgery for an application of a new long leg cast. The patient required surgery due to a traumatic fracture of the lower leg. Okay. Well, we're going to be doing real simple right now. And I don't know if you've noticed that. You're really only coding for the specific system we're in. Have you recognized that yet? Okay. So you don't have to get into the fact that the physician, he's an established patient returning post-surgery, blah, blah, blah. Because you would be coding more. Okay? So what happened here? What in the encounter happened? He went to the doctor's office for what, Emily?
Initially, well, right now he's going there for an application.
Of?
A new long leg cast.
Yes. Perfect. So we're going to look up cast. And then what kind of cast? A long leg cast. So go ahead and start with that. All right, what do you have, Lisa?
I was talking and had my microphone off.
Sorry. All right.
The CPT code 29345,
Yes.
and I was
And
still
do you have a
looking.
modifier?
No,
Okay.
but it would
Go ahead.
be, is it a 50 or a 51?
It's a 58.
58, I was wrong on both ends.
That's okay. What do you think we would look up for our ICD-9 codes? Emily, what kind of codes do you think?
Traumatic fracture. Right?
Well, first we're going, what kind of a visit is this?
Oh, it's
Post-surgery.
he's in a state.
He's returning post-surgery for an application. The patient had required surgery, so basically he's having an encounter for fitting of the orthopedic cast. So it would be an admission or an encounter. That's our first code, and it ends up being a V code. And then the second code is an aftercare fracture code. Because the fracture's healing and the patient is basically being seen for the cast change.
Some of these are really hard to pick out the right. I mean, I must just look at it and look at it so much, I don't even see what to take back.
Right. So because he returned to the physician's office, it's an encounter or an admission, okay? Always when we go to a physician's office, it's an encounter, all right? So what is he doing at that encounter? He's having a fitting or application of the new cast, okay? And then what else happened? He's having aftercare. Aftercare happens when we have casts and strapping and stuff like that. Okay? So just keep that in mind for the diagnosis codes, and you can look those up on your own with your assignments. How about 23? 23. Julie Mason, age 5 years, is coming in today to have her long arm cast removed and replaced with a short arm cast for 3 weeks. The patient sustained a torus fracture of the upper end of the radius and is 1 week post-op. Same thing. She is actually getting a short arm cast. She's having her long arm cast replaced with a short arm cast. So we would look up the same thing. Cast, short arm. And our diagnosis codes would be similar to the one before. Encounter for fitting, and then aftercare. Okay, do you think you have it, Darla?
Pretty close.
Okay.
I got the CPT code.
Okay, tell me what it is.
29075.
Good job. Okay. All right, what do you think you have for the diagnosis codes then, Darla?
It's taken me, well, I got a V5421 so far, but I probably should be looking at fracture now, right?
Okay, well, no, hold on.
Okay.
So the first diagnosis code is for the encounter, for the orthopedic cast. So that would be V53.7. The first thing you're going to look at is either admission or encounter, fitting of the orthopedic cast. That's how you would look that up. And then the second code, you were close, it's V54.12, aftercare fracture traumatic arm lower.
Okay. Yeah, I looked up aftercare first. Yeah.
Yep.
Okay.
All right, so let's 24. Let's take a look at 24. And let's we'll just do the CPT codes for now. You can do the diagnosis codes at home. We'll talk about them so you can get an idea of what you're looking for. 24, Jamie Larson slipped on the ice and twisted her knee when she fell. During diagnostic arthroscopy, a buccal handle tear of the medial and lateral meniscus was seen and repaired. All right, so what are we going to start with?
Arthroscopy?
Arthroscopy, yes. What type? Surgical. Knee. Arthroscopy, surgical, knee. I'm going to step out just for a sec.
I think my head's just fallen.
Lisa, do you think you have this one?
Nope, I cannot find it. I have
All
gone
right.
through and gone through them.
Emily, did you find it?
I think maybe.
Okay.
That's the right one. But I had 29870.
Close. 29.
That sounded
Close. 29883. So let's start with arthroscopy. Go
See,
to
I
your
hadn't
book,
got that.
arthroscopy. In the back.
Yeah. There it is.
That's why I see what
A couple more pages and I would have had it.
Okay, surgical and knee. And then you go to those codes and you take a look. Okay? For your diagnosis codes, you're actually going to have 3 here. They give you 3 spots. The first one is the tear of the meniscus. And you're going to have 2, one for tear of the meniscus medial and one for tear of the meniscus lateral. And then you're actually going to have an E code because they slipped on the ice. You would not code a diagnostic arthroscopy here because that's already included in the first code. Let's look at 25. What are the main words here that we would start looking up? We have a percutaneous skeletal fixation of a closed calcaneal fracture requiring manipulation. What's the counter for? A fracture, right?
Yep.
What kind of fracture? Calcaneal fracture. And it was with manipulation. So you would be fracture, calcaneus with manipulation. Look it up. What do you think, Emily?
28406.
28406. Do you ladies concur?
I'll find it.
How'd you find it, Emily?
Fracture. And then,
What page?
oh, in here?
Yep.
155.
Okay, 155 in the tabular.
And at first I thought it was the 28400, and then I kept reading because that's why I'm wrong, because I don't keep
We don't read enough. We don't read far enough down. Do you see it, Lisa? 284.
Yeah.
Okay. All right. Next one, number 26. That's pretty much same as the 25, fracture of the pelvic ring. Let's look at 27. closed treatment of a single closed metacarpophalangeal dislocation distal end with manipulation and without anesthesia. Well, what's the body site?
Foot.
It's a foot.
It is the metacarpophalangeal. So you're going to look up metacarpophalangeal joint. Dislocation, closed treatment. Okay, Darla, what do you have?
I don't have it yet.
Okay.
Am I close with a 28510 and 28505?
No,
Not even anywhere near it?
no.
Oh my lord.
Did you go to metacarpophalangeal joint? Start there.
I have to really work through this. Of knowing where everything is.
Hold on. All right, page 873 in your index in the back of the CPT book. Metacarpophalangeal joint, right hand column, page 873.
Did you say 873 in the CPT?
Yes. Did you find it? Then dislocation and closed treatment.
Yeah, 226, 740.
It's just how we see it because we're looking real quick. Yes, you should wear your glasses.
26740.
No, 26700 because you went down to fracture articular
Mm-hmm.
instead of dislocation. Because it specifically says dislocation.
Yeah.
It's also late at night. We're tired. Okay? So let's run through these and just pick out the terms that we're going to be looking up. On number 28, we have open treatment of a closed traumatic anterior hip dislocation without fixation. We are going to start with what, Emily?
The interior hip.
Well, what happened first?
The dislocation.
The dislocation. The dislocation of what? The hip joint. And what type of treatment? Open treatment. Okay, that's how we would look that one up. Number 29, closed treatment of a patella fracture, no manipulation. We have a fracture. Fracture of what? The patella. What type of treatment? Closed without manipulation. All right. 31. Let's look at 31. Manipulation of a knee joint under general anesthesia with application of a traction device. Patient had an anterior dislocation of the tibia proximal end. Well, this one is really simple. Darla, where do we start?
Dislocation?
Nope,
Is it
it's a
that simple?
manipulation. Manipulation.
Wow.
Manipulation of the knee. All right, over on page 117, number 32. Closed treatment of a closed tarsal bone dislocation without anesthesia. Again, we have a dislocation of what? The tarsal. And is it with or without? Nope, sorry. What kind of treatment?
Right.
Closed. All right, 33. Depressed frontal sinus fracture repaired using open treatment. Remember, these are not your. So what is going on here? Fracture of the sinuses, right? So we're going to start with what? The
Fracture.
sinuses.
Oh, sinus.
What? Where?
That was where, right?
Frontal. Okay. And then what is a fracture? And what type of treatment?
Depressed.
Actually, open treatment.
I said just like I am right now.
So what was the first one we looked at? We looked at fracture first? Or we
Actually,
looked at
sinuses, frontal sinuses,
Okay.
okay? And then it's going to be fracture and open treatment. All right. 34 is a fracture of the maxilla. That would be open treatment. What you have to remember with musculoskeletal is the body site. Okay? Then what kind of treatment? And then is it with or without manipulation if they have it in there? Okay? All right. All the others you should be pretty good on. They're talking about removal of the halo, aspiration of the shoulder joint. Turn the page to 118. Number 45. They're talking about wedging of a clubfoot cast. Well, what are they doing? It's a cast. A cast of what? Wedging. Believe it or not. Strapping, number 49. Strapping of what? Thorax. (52) Arthroscopy. What kind? Surgical. To what site? Elbow. Over on 119, number 57. Release of a transverse carpal ligament of the wrist with surgical endoscopy. Ligament. What are we working on? A ligament. What are we doing? We're releasing it. And of what? The transverse carpal. Okay? Try the reports if you're able to. At least do 62 and 64. Next week, assignment for next week. It is. Next week we are on week 15, chapter 20, and chapter 21. That is respiratory and cardiovascular. If we need to take more time next week, we will. Cardiovascular tends to be not everyone's favorite, but I want you to try. That's all I'm asking is try. Okay? Lisa, what's your takeaway from tonight?
That I really need to read more and not jump to an answer. I need to read down and make sure I have everything in alignment.
I can honestly say that is probably 98% of everyone's problem. Believe it or not.
And
How about you,
before I
darling?
forget,
How about you, darling?
Oh, there's just so many different places to look up now. It's like, and trying to remember the rules of, what you look at first and then go from there.
Yeah.
But I'm behind, but so.
I still want you to take it one thing at a time.
Yep.
Okay? When you have time, you can go back, but try to do what you can now.
Okay.
Emily?
Like she was saying, was reading everything. I need to get a new prescription for my glasses, but.
So reading everything and making sure you're wearing your glasses.
Yes.
Okay. And what were you going to say, Lisa?
please don't forget to send me the lecture, because I'm not going to be here next week.
Yep. All right. So next week,
Wait,
and then
can I
we have
ask you one
break.
other thing? One
Next
more
week,
thing?
and then we have break.
Okay, so I won't be here. Oh, it doesn't. That's all right, but you will check on those answers for me.
Yeah, I usually get to all of those kinds of questions on the weekend.
Okay, yeah, because you had asked me some questions back and I sent it.
Yeah. Okay. Then have a great week, ladies. Thank you very much for your time tonight. I really appreciate it.
Night.
Bye.
Bye.